So let me now continue my previous episode. This is my second episode about the water and the human body. And now I will talk about after I have finished talking about the normal physiology and functions of water and the anatomy of water distribution inside the human body. Let me now talk about another issue, which is what is edema, or fluid overload states, or sometimes we call it water overload states, or sometimes we call it hypervolemia. The term edema means that there is an increase or accumulation of fluid somewhere in the body, accumulation of fluid somewhere in the body, causing swelling of that part of the body. And there are different classifications of edema. We have peripheral edema, which is accumulation of fluid in the interstitial compartment, causing an interstitial peripheral edema, or interstitial edema in the subcutaneous tissue of the periphery, mainly in the ankles or in the hands or in the arms or in the legs. This is called peripheral edema. Or it may be due to excess fluid accumulation in the lungs, what we call pulmonary edema, whether in the interstitium of the lung or inside the alveoli or the parenchyma of the lung. This is what we call parenchymal pulmonary edema. So whether interstitial or alveolar or both, this is pulmonary edema. Or maybe fluid accumulation inside the brain and the interstitial and the intracellular and extracellular spaces of the brain, that is in the interstitium of the brain, or in the brain substance, causing brain swelling. And this is cerebral edema, which is dangerous and causes high intracranial pressure, and it may be life-threatening and causes death if not properly treated, and if the cause not properly identified and treated. This is cerebral edema. Or maybe some other edema in localized in the eye, in the macula, and this is what we call macular edema of the retina of the eye. So we have peripheral edema, we have cerebral edema, we have pulmonary edema, and we have macular edema. We have also dermal edema in patients with a lymphatic obstruction of the skin, like by cancer, for example, causing body orange sign. This is dermal edema. We have epidermal edema in patients with dermatitis and eczema, causing a positive thumbprint sign. So, and we have the subcutaneous edema or the peripheral edema, which causes pitting, or what we call pitting sign of the subcutaneous edema. These are different classifications of edema depending on its site, on its anatomy. So as we see, we have different types of edema, that is accumulation, abnormal accumulation of water, abnormal accumulation of fluid, resulting in swelling of a part of the body, or maybe the whole body. Let me first talk about, or come to talk about, or focus on the subcutaneous edema, or what we call the peripheral edema. Subcutaneous edema, it means that there is increase in the interstitial accumulation of water in the interstitial fluid, and we all know that the interstitial water, as I mentioned, normally it is formed by transcapillary filtration of water, transcapillary filtration of water, which is then absorbed by lymphatics. So this is the interstitial fluid. If this amount of interstitial fluid is increased, we get interstitial edema or subcutaneous edema. And the usual mechanisms of edema, subcutaneous edema or peripheral edema, are increased capillary hydrostatic pressure or decreased plasma oncotic pressure, or increased the hydraulic capillary permeability, or what we call capillary dilatation. And the fourth mechanism is lymphatic obstruction. So these are the four mechanisms of peripheral edema or subcutaneous edema or interstitial edema developing in the subcutaneous tissue of the body. Either increased capillary hydrostatic pressure or decreased plasma osmotic pressure, or what we call oncotic pressure, and this is related to the plasma protein content of the blood, mainly the albumin. When there is hypoalbuminemia, this will encourage the formation of water from the intracellular to the extracellular into the interstitial compartment with interstitial edema. So either increased capillary hydrostatic pressure, and this is mostly related to the sodium content and the level of, especially to the level of aldosterone, and the presence of primary hyperaldosteronism or secondary hyperaldosteronism, etc. Whatever the underlying cause of secondary hyperaldosteronism in patients with renal failure or liver cirrhosis and liver failure, or patients with heart failure, which are the main causes of secondary hyperaldosteronism. So this is one mechanism, or primary hyperaldosteronism, and this is a different pathological group of disease. And this will increase the sodium content, will increase the hydrostatic pressure, and it will encourage the pathogenesis of edema. So increase the capillary hydrostatic pressure, decrease the plasma oncotic pressure related to hypoalbuminemia, and any cause of number 3 is increased capillary permeability, or what we call increased hydraulic capillary permeability. And number 4 is the lymphatic obstruction due to impaired drainage of the interstitial fluid, which is already filtered through the transcapillary forces, as I mentioned before. So it's either increased the formation or decreased drainage of interstitial fluid. Any disturbance of these two mechanisms will cause or increase the capillary permeability due to direct inflammatory injury by oxygen radicals and other oxidizing radicals and other oxidizing forces on the capillaries, causing capillary dilatation and increasing capillary permeability with increased filtration of water into the interstitial tissue. So these are the 4 main mechanisms. Any disease which cause edema and which encourage interstitial edema and subcutaneous edema and peripheral edema causes it through one of these 4 mechanisms which I mentioned. Increase the capillary hydrostatic pressure, decrease the plasma oncotic pressure, increase the capillary permeability, or lymphatic obstruction. This is the regardless of the cause of edema, whether it is generalized, which, as I mentioned, mostly related to organ failure, liver cell failure, renal failure, and heart failure, and even in patients with respiratory failure with hypoxia or hypercapnia, which also encourage peripheral edema formation. So all organ failure can encourage edema formation. Respiratory failure, heart failure, liver cell failure, and renal failure. These are the 4 main causes of edema, which usually starts localized, and then in the peripheries, the ankles and the arms, and then gradually it becomes generalized, affecting the whole body, which we call it anasarca, or generalized edema. And this is subcutaneous edema due to organ failure. Maybe also the edema due to local factors. Most common local factors of edema is either venous causes, like what happens in DVT, causing, of course, venous edema as one of the features of deep venous thrombosis. Peripheral deep venous thrombosis also may be due to lymphatic causes, like peripheral lymphatic obstruction by local factors or malignancies or parasites, etc. Or also may be due to inflammatory causes, like what happens in infections of the skin, in cellulitis or in erysipelas, or other infections or inflammatory lesions of the skin. So inflammatory lesions or of the skin and subcutaneous tissue, or venous causes or lymphatic causes, these can cause local edema in the periphery, either bilateral or unilateral. Apart from the generalized causes which I mentioned, the organ failure, heart failure, renal failure, liver cell failure, advanced cirrhosis with liver cell failure. Also in patients with hypoalbuminemia, in patients with malnutrition, like kwashiorkor, especially patients, protein energy malnutrition and kwashiorkor, they might present with edema due to hypoalbuminemia, and also in some forms of allergy. Another endocrine disease causing also edema or mixed edema, special type of edema, we call it mixed edema, is hypothyroidism. So these are all causes of peripheral edema or subcutaneous edema, and I already mentioned the mechanisms of the peripheral edema. Then we have another type of edema, which is the pulmonary edema, and the pulmonary edema is related, of course, to either to a cardiogenic cause or to a pulmonary disease. Cardiogenic as left-sided heart failure, any left ventricular failure due to myocardial infarction is the commonest cause and the commonest example of cardiogenic pulmonary edema. So pulmonary edema complicating acute MI, or complicating devastating arrhythmia, like uncontrolled AF or uncontrolled VF or uncontrolled V tachycardia, V tachy. So whether it is edema due to left-sided failure or as a result of MI or arrhythmias or cardiomyopathy or whatever, pulmonary edema due to cardiac left-sided failure. Acute pulmonary edema complicating left-sided heart failure of whatever cause, as I mentioned. And also we have pulmonary edema complicating a pulmonary disease or pulmonary insult, like pulmonary edema complicating massive pneumonia or severe pneumonia, pulmonary edema complicating inhalation of toxins and toxic chemicals. This is exogenous factors. So pulmonary edema can or result from an intrinsic disease in the lungs or in the heart, or from environmental inhalation factors. There's a form of chemical or toxic injury to the lungs. So this is the or pulmonary edema can also result from acute renal failure, especially acute oliguric renal failure with hypervolemia. So it is pulmonary edema is in fact a manifestation of what we call fluid overload or hypervolemia. So it can be due to hypervolemic status, whether due to inadvertent administration of fluids inside the human body, orally or parenterally, commonly intravenous. If there is unwise administration or inadvertent administration of IVF, especially hypertonic fluids, or too much intravenous fluids, that is the problem in the quantity of fluid or in the quality administered into the human body. The patient might develop a state of hypervolemia and pulmonary edema. So hypervolemia or fluid overload or water overload state, whether due to intrinsic causes or due to iatrogenic, due to extrinsic factors from outside, that is, it might be, as we all know, the edema might be related to a medication. That is, the fluid overload might be related to a medication, might be related to pregnancy, which is a physiologic condition, might be related to an underlying disease, as I mentioned, in organ failure, heart failure, liver failure, renal failure. These are all causes, or the three main important causes of edema are medication, pharmacologic, physiologic, that's pregnancy, or pathologic, that is underlying disease. And most common is organ failure causing peripheral edema, as I mentioned, or even up to pulmonary edema, as I mentioned right now. So these are all the different causes of edema, peripheral edema and pulmonary edema. This edema is just an expression of fluid overload or water overload or hypervolemia. It manifests with edema, and this edema describes excess fluid accumulation within a certain area of the body, maybe in the subcutaneous tissue, peripheral edema, maybe inside the lung, pulmonary edema, maybe inside the brain, cerebral edema, maybe only in the eye, whatever. So it might be localized or generalized, depending on the underlying cause or the underlying pathology. The main features of fluid overload, as I mentioned, is number one, increase, and the earliest feature of fluid overload is increased body weight. That is the early sign detecting increased body water pathologically, even before it is clinically apparent as edema. What is the earliest sign before edema? Is increase in the body weight. So increase in the body is the earliest sign of fluid accumulation or fluid overload or water overload, body weight gain. So by just measuring the body weight, we can detect any fluid excess or water excess. Then after that, we start to appear the edema, or the accumulation of fluid in the subcutaneous tissue or inside vital organs, pulmonary congestion, pulmonary edema, or cerebral congestion, cerebral edema. And number three, hypertension also. So hypertension is a manifestation of hypervolemia. So increase in the body weight, edema formation, and hypertension are all clinical manifestations of fluid overload. And by monitoring the body weight and by monitoring any pitting sign of peripheral edema, and by monitoring the blood pressure, we can monitor the fluid status or detect any fluid overload or water overload states as early as possible. Depending on the increased water content site, whether it is in the periphery or inside a vital organ like in the lung or in the brain, will be the other clinical features. For example, in patients with cerebral edema, the patients with cerebral edema will start to get headaches, nausea, vomiting, seizures, disturbed level of consciousness, and even coma and death in advanced cases. So headache and nausea and vomiting and seizures, that is abnormal seizure activity, and disturbed level of consciousness, drowsiness, passing into further deeper states of disturbed level of consciousness. These are all manifestations that there is water developing within the brain, that is cerebral edema. In pulmonary edema, the earliest features are shortness of breathing and chest tightness or chest discomfort and the cough, and then maybe even sudden death due to rapid accumulation of water inside the lungs, as it happens as a complication of acute myocardial infarction. So shortness of breathing and cough and chest pain or chest discomfort are manifestations of developing pulmonary edema, and you should immediately seek for medical advice. So the other features of fluid overload depend on which organ is affected and which tissue is affected by the fluid accumulation. But in general, as I mentioned, weight gain and edema and hypertension are all early features of fluid overload, as systemic fluid overload in general. Local overload in the brain or in the lungs, this is different. I will have another separate presentation about pulmonary edema only, and another live video about cerebral edema in clinical practice. Thank you so much, and I hope that these videos about water and distribution of water and fluid overload states in clinical practice will be beneficial to all of the clinicians who listen to my presentations. Thank you so much, and have a nice and peaceful day.